Hi everyone, welcome back to Karlee's Farm. I've just thought I'd pop in really quickly and just talk about antiplatelets. It'll only take a couple of seconds because they're actually fairly quick and fairly easy. So I just wanted to remind you about the process of what happens to cause platelet aggregation. So a platelet is activated, so usually through exposure of the endothelium or some other injury, and it goes through a couple of different pathways, and it's not necessarily linear. Some of these sort of happen concurrently, but essentially it can activate COX-1, which in turn activates thromboxane, which in turn activates the glycoprotein receptors on the platelet. Now, at the glycoprotein level, there are some little receptors that are associated with the glycoprotein receptors called P2Y12 receptors, and they're important because that's one of the drug classes can act there. When platelets are activated and they go through this pathway, they activate more ADP production. And so it's a cyclical feedback. It's a positive feedback loop. Once the glycoprotein receptors are activated, more ADP is produced and more COX-1 is induced as well. And then the final step, once the glycoprotein receptors are initiated or turned on, they then cause fibrinogen linking between platelets, and you get platelets that are then clumped together. Now, which ends up being platelet aggregation. Now, there's really only a couple of different types of antiplatelet agents. So the most common one and the first one ever made, the original and the best still, is aspirin. So aspirin, particularly in low doses, aspirin is used for platelet aggregation and usually inhibition of platelet aggregation. And usually that dose is between 75 and 150 milligrams a day. So aspirin, as we know, inhibits COX-1, which inhibits thromboxane production. The other main oral group of antiplatelet agents are called the thienopyridines. Now, these agents essentially block the binding of ADP to the P2Y12 receptors, which go on then to inhibit glycoprotein receptors and stop this fibrinogen linking. Now, these thienopyridines, there are three main drugs in this class. So this is clopidogrel, prasugrel, and ticagrelor. And really the outcome's sort of the same, but there's some data that says that probably prasugrel and ticagrelor are more potent than clopidogrel, but they also cause more bleeding. So depending on the indication and what you're using them for will depend on which one is chosen. And also the other thing that matters too, of course, is your comorbidities, age, etc. So that's the other oral group. Now, aspirin and the thienopyridines, they can be co-prescribed. So there are certain conditions where you actually do need both. So you need both aspirin and, say, for example, clopidogrel. And that is called dual antiplatelet therapy. And there are certain indications where that is always advised. So following a cardiac stent insertion for a period of time, you need dual antiplatelets to prevent platelet aggregation on the stent. There's also some data for them in ischemic stroke in certain conditions, in certain situations for short periods of time. So they can be co-prescribed. And the third and final group of antiplatelets that I wanted to mention are the GP glycoprotein 2B3A receptor antagonists. So they directly inhibit the glycoprotein receptors on the platelet. These particular agents currently are only available intravenously. So they are used short term in very specific indications, most commonly in cardiac stenting, where immediate and significant platelet aggregation inhibition is required. So it's usually just short term for the duration of the procedure, plus or minus some time following that procedure. And so I guess that's the three main classes. That's where they act. It's pretty straightforward. I knew it'd be really quick. I guess the only other thing to mention, of course, is what sort of side effects we would be looking at for the antiplatelet agents. And just as you would expect, there's an increased risk of bleeding with antiplatelets because you have less platelet aggregation. And there's some other sort of rarer and more idiosyncratic side effects, particularly with the thionopyridines. Some of them have been known to cause bone marrow suppression, although these other side effects are really quite rare. So they're fairly well tolerated overall, rather than the bleeding risk. Okay, thanks for joining me. I'll see you again soon.